My presentation is on anterior cord syndrome, aka anterior spinal artery syndrome, and aka Beck's syndrome. All three names are used in the literature interchangeably, so you'll often see them used to describe the same thing. So what is anterior cord syndrome? Well, very simply, anterior cord syndrome is the result of a compromise to the anterior spinal artery, but it can also be caused by direct compression of the anterior spinal cord. It's also kind of interesting to note that damage to the anterior spinal artery is actually the most common cause of spinal cord infarction out of all the different spinal cord syndromes. So understanding the locations and purposes of the anterior spinal artery and anterior spinal tract are important for understanding how anterior cord syndrome can develop. So the cord is supplied by one anterior spinal artery. You can see that along here. And then there's two posterior spinal arteries. And the anterior is responsible for supplying blood to the anterior 2/3 of the spinal cord, which is this portion here. The anterior portion of the cord contains the corticospinal and the spinothalamic tracts. And when the anterior cord syndrome is present, it's manifested by changes to the functions regulated by these tracts. So this is just a picture of a cross section of the spinal cord showing what each tract is responsible for. And then when there is a disruption of blood supply to the anterior spinal artery, it affects all of this area down here. So it kind of makes like a U shape, this. And it's everything that's below here that gets impacted when anterior cord syndrome is present. So that's going to affect this tract here. And this one. This is just another picture of the spinal cord showing where anterior cord syndrome impacts it. So it's all this grayed out area here. As you can see, the spinothalamic and the corticospinal tracts are being impacted by the reduced blood supply from the anterior spinal artery. So there's some sort of blockage here, and because of it, you're getting ischemia in this whole area of the spinal cord. Other than trauma, as I mentioned earlier, any occlusion of this artery will lead to ischemia of the spinal cord. Injury or compromise to the anterior spinal artery can occur through a variety of mechanisms, including flexion, injury, or horizontal forces, which are not really that common, external compression from things like a tumor, abscess, or herniated disc, vascular disease, which occurs in exactly the same way atherosclerosis can lead to a stroke or an MI, and it's sometimes called spinal stroke, which we're going to talk about later. But basically, it's just atherosclerosis leading to plaque formation and rupture. And then aortic pathology refers to things like aortic aneurysms, thrombi, dissections, and even aortic surgery or interventions can lead to damage or occlusion of the anterior spinal artery. So obviously these are only a few examples, but basically anything that can compromise the anterior spinal artery, causing ischemia to the anterior spinal cord, can lead to anterior cord syndrome. These are just some examples of flexion injuries that we may encounter on the road, but really any injury that causes that chin to chest flexion can lead to a significant flexion injury and therefore anterior cord syndrome. So the clinical manifestations of anterior cord syndrome, as we saw a few slides back, the lateral and ventral corticospinal tracts are responsible mainly for voluntary motor control, while the lateral spinothalamic tract is responsible for pain and temperature, and the ventral spinothalamic tract is responsible for light touch. So when someone is experiencing ischemia to these areas of the spinal cord, they will therefore experience bilateral motor loss, and loss of light touch, pain, and temperature. They will, however, have preserved proprioception, vibration, and deep touch because those are located in the posterior column. The intensity of these deficits, however, depends on the location of the injury or occlusion. So for this reason, the upper extremities may or may not be affected, but the lower extremities are always going to be affected. And then depending on injury location, the person may also experience orthostatic hypotension, autonomic dysreflexia, which is acute uncontrolled hypertension, bladder and bowel dysfunction, sexual dysfunction or priapism, neuropathic pain, and gait impairment. So the most immediate life threat associated with anterior cord syndrome is autonomic dysreflexia. If the injury occurs at or above the level of T6, there can be a reflex sympathetic discharge that causes life-threatening hypertension. And if it's not recognized and corrected immediately, seizures, pulmonary edema, renal insufficiency, myocardial infarct, or cerebral hemorrhage can occur, and that would lead to death of the patient. Long term, the life threat is associated with bilateral paralysis and even quadriplegia. It's associated particularly with decreased movement, pressure ulcers, and infection, so anything that's kind of related to immobility. Overall, anterior cord syndrome has a very poor prognosis. Only 10 to 20% of patients will have full recovery of their movement, while 50% will have little to no improvement of their initial symptoms. There is a 20% mortality rate associated with anterior cord syndrome, and the treatment, therefore, is focused mainly on the primary cause of the syndrome and overall supportive care for the patient. So as an ACP, because anterior cord syndrome is more likely to occur due to a vascular problem rather than traumatic, it's essential to do a thorough assessment of the patient's history and current presentation. Identifying risk factors that increase a patient's chances for experiencing an MI or stroke, such as smoking history, diabetes, cholesterol, hypertension, AFib, those are all important risk factors for the development of a spinal stroke and therefore anterior cord syndrome. If a patient is complaining of sudden onset back pain followed by bilateral weakness and numbness, the ACP's index of suspicion should be high for anterior cord syndrome. And it also has a very rapid onset. Paralysis can set in within minutes of onset in some cases, but may not have a distinguishable cause or mechanism of injury. So gaining a very thorough history is essential. The ACP should also be aware of the clinical manifestations, especially autonomic dysreflexia. So establishing IV access to mitigate any symptoms of a rapidly increasing blood pressure would be good practice. Think, for example, seizures. So this is the question that I've decided to pose for you guys. As I described throughout this presentation, anterior cord syndrome can result from an occlusion of the anterior spinal artery due to a ruptured atherosclerotic plaque, an embolus, or a thrombus. There are some very definitive treatments for patients experiencing a stroke or an MI, such as TPA, ASA, and cardiac catheterization. So then, what about spinal stroke? It's basically the same thing, right? So my question is it reasonable, therefore, to consider treating a patient who is experiencing a spinal stroke with similar treatments in order to reduce ischemia to the anterior spinal cord? What might be some of the implications or concerns for this type of treatment, and would it even be effective? Consider this finding, though. So a clinical trial of the efficacy of naloxone in humans using a 5.4 milligram per kilogram IV bolus, followed by 4 milligrams per kilogram per hour constant rate infusion for 23 hours, revealed improvement in descending motor function in patients with incomplete spinal cord injuries if administered within 8 hours of the injury. So that's just maybe something to think about when you answer that question. The study is here, this Bracken and Holford, but they couldn't get full access to the article. So this quote is taken from this article, and all of the references are here for you to take a look at.